So that up there is where my office is, and up here, right here at Weston, is where Dr. Richard Herman, one of our faculty, is staying. So I'm meeting up with Richie because he's in town in Boston visiting. He's giving a presentation tomorrow at the BU Dental School, the postdoc endo program. And I asked him to see, he's going to meet me up for dinner, and I figured we'll also maybe share a couple of slides from his presentation tomorrow with you guys. Dr. Richie Herman. How are you?
You are unbelievable.
Good to see you, man. Hi, Richie. Thanks for doing this. I really appreciate it. So Richie's here giving a talk tomorrow to the Boston University postdoc endodontic department, to all the residents, the new residents and the old ones and so on. You do this on a yearly basis, correct? You've been coming here for a number of years now, doing this for the BU students. I'm sure they appreciate it. And I figured, so since you and I are going to meet up and have a little bit of dinner and going to catch up, since I haven't seen you so much and I like you so much, Richie. So I figured we'll just talk a little bit of endo. And he just showed me a couple of cases that you just did at the office. And that's the amazing thing. Every time I see Richie, he's still at the tender age, practicing, seeing patients, and every time I see his cases, my jaw drops. I'm like, I wish I could be only half as good as you are, man.
I mean, your cases are amazing.
No way. He is awesome, and actually, you'll see just a couple of cases that he just showed me here on his iPhone that I wanted to just talk about and see how you did them.
Okay.
All right. So the first one here is the maxillary second molar. And it looks like it's obviously pretty far back here. There's a crown on there, right?
Yes.
So what were the symptoms? What was the chief complaint?
Chief complaint was he had a little bit of pain, nothing spectacular.
Yeah.
A little pain on percussion, a little pain on palpation. And kind of like a routine case. Mm-hmm. And so we used local anesthetic.
Yeah.
We gained access. So
irreversible pulpitis and kind of a normal or just maybe acute apical periodontitis, or at least, just a little bit of just the beginning part of it. Right. So you went in there and access
a
microscope, right?
Yeah, I like to just say one thing. Whenever I do access now, I think an ultrasonic instrument is invaluable, and I use that a lot. My access, I get straight line access, and I use the ultrasonics.
Yeah.
To get to the orifices. Then I use a 2008. I open up the orifice. Then I always use a hand file. I don't think hand files are obsolete. I still like to make my glide path. So I'm comfortable getting to a 10, most of the time to a 15, and then I switch over to my rotaries. So now what we have is our new protocol called EndoSequence Blend. So EndoSequence came out in 2004. EndoSequence X, which I like to call EndoSequence Express, came out in 2013.
Yep.
And we're going to combine it now with the newest instruments that just came out a couple of months ago called Scouts, EndoSequence Scouts. And so it's a blend. And so what I'm finding now is if I divide the canal into halves, and I start with my EndoSequence, which are non-heated, I go about halfway down. And then I switch over to the Scouts, probably start with a 2504. Now they're heat treated, so they're very, very flexible, and they follow the canal, they follow the curves beautifully. So I get down there, I switch over to a 2004, and I get to just about my working length. And then I go back to my hand file to make sure it's patent. And then I switch over to the whole thing. I go down with a 3004 EndoSequence, non-heated, and I blend in the two halves of the canal. So I did that basically in the two buccal canals. The parallel canal, I did not use the Scouts because the 3004 goes down very easily.
So this is the final x-ray. It looks beautiful. Look at that huge curvature you had on the mesial roots. And it seems like getting around that kind of a curvature, this type of a combination of using a non-heated, more efficient type of an EndoSequence in the upper half of the tooth right before you reach the curve, and then using a heat-treated landed file such as the EndoSequence Scout to get around it and enlarge it to a safe size like a size 20 or 25 before coming back with an EndoSequence to blend the whole thing in.
Right.
Seems to be a ticket. You have no transportation. Everything looks beautiful and well filled. What size cones did you use in each one of these canals for filling? Is hydraulic condensation?
I only use hydraulic condensation now.
Yeah.
I think it's the way to go.
Yeah.
I think bioceramics is one of the great things that has happened in endodontics over the last 10 years, and the literature supports it now.
Yeah.
So on the palate, I went to a 3504, and on the buckles, the distal buckle, I went to 3004, and I went to a 2504
On the mesial buccal,
yeah.
because of the curvature. That's pretty wise, because
Yeah.
you don't want to put a very
Right.
large size, non-heat treated
Right.
file at the end
Right.
to blend the whole thing and
Right.
give it that size of curvature.
And I'm a
So-
big fan now of minimally invasive endodontics, but that's instrumentation. That is not access.
Yeah.
Okay, so that's my philosophy and that's my protocol.
Well, I think this is a perfect shaping size. You have just adequate coronal shaping, and the apical shaping is adequate. So that's terrific. So let's quickly take a look at the other case as well. All right, and so this is the another case here you just did, which is a silver point through a crown. Seems like a fairly large, kind of a sombrero-like crown, right? You're probably going to replace the crown after the endo. And you're having an apical lesion going on.
Right.
So tell us, it looks like you did remove the silver points through the crown.
Right.
What's your trick? What do? You give yourself an ample access opening up on top?
Yeah,
too?
I opened it up pretty wide. You know, I tried, the dentist wanted us to keep the crown, the patient wants to keep it. I think it
Oh.
really should be redone.
Yeah.
It's not adequate. But anyway, we go in there, and I go in there, I gain access very gingerly. And then I switch over all the time to my ultrasonic unit.
Yeah.
And I go around, and these weren't hard to get out. They were located pretty good, and they came out very, very quickly.
You know what I found, Richie, is that when you have silver points that have been there for this long, if they are failing, then they're easy to get out because it means that they've lost their seal, right? But if they're actually they're asymptomatic and you have to replace them or remove them for the purposes of a post or something, then they're actually more difficult to remove because they've been so well done, they're actually sealed.
Yeah.
But once there is infection involved, then the seal is lost, and therefore those are usually a lot easier to remove. Now, what I've found also when you do the access preparation and you're using your ultrasonic, it's very important, even before when you use the burr, not to cut the top of the silver points off.
Never.
Right? So that's where you have to be really careful.
Really careful, because then
Right.
you're gonna cut it at the orifice, now you got a problem.
Exactly.
Right.
So to be able to isolate them and then not cut them off with the burr and then switch to the ultrasonic so that you can actually remove, as you said, more gingerly and more carefully
I
around.
peck everything around it, and then all of a sudden I see the silver cones, and I take a
Styglitz.
slide glitz, and
Yeah.
it comes right out.
Yeah, it's nice to vibrate. Another trick is to actually hold it with the styglitz if it's tight as you pull back, and then use the ultrasonic on the tip of the styglitz and activate
That's
the
an
styglitz.
interesting thing that you say like that, because I take out, it happens very, very rarely, but you know, I teach at a university, and sometimes we get a fractured instrument, a separated instrument, so that's exactly how I do it.
Nice.
I take the ultrasonic, I put it on I try to get it alongside the fractured instrument, and then I vibrate it out.
Yeah,
So that's pretty cool.
That's terrific. All right, I mean, there's a bunch of cases you've just done over the past week that you were just showing me that they're really incredible, but we want to keep this one short, so it's been so, thanks so much for spending a little time here with our audience to talk about these, a couple of these cases that you've done recently, and, you know, I'm starving, aren't you?
Ali, thanks so much for having me. You're amazing, and I'm very
All right.
honored to be working with you.
All right, boss,
So I
let's
appreciate
go grab a bite to eat.
it. Okay, so that's good.
Here we go, burger time. All right, I guess it's time to eat. Richie, thanks so much for the video, and I guess we'll see you in the next video. Until then, let's save some teeth.
Okay.